Yeah. Okay, good morning, everyone. We can get started. Thank you for joining us today. So we have, again, two wonderful presentations. Our first presenter is Dr. Amy Xu, who's a postdoctoral fellow at OHRI, and of course affiliated with the university, and her main focus is using ICES data, working on health administrative data. She is working with Doug Manuel. She has, her PhD is in health economics from the University of Toronto. She's currently working on several projects to looking at the economic aspect of end-of-life care and healthcare usage. Thank you.
Oh, perfect. Thank you. Good morning, everyone. Delighted to be here this morning. 40 minutes is quite a long time for someone to be speaking. So I think I will welcome a couple of questions throughout the presentation. And also, because we're going through several projects, I think sometimes questions might arise. And I just don't want to, lose your engagement in the project. So I'll take a couple questions throughout the presentation, but I'll definitely keep an eye on the time so that we don't end up going over the allocated time. So again, my name is Amy Xu. I'm a postdoctoral fellow working with Doug Manuel and Peter Kenny-Petruccio at OHRI, and most of my research involves the use of ICES data. So ICES stands for Institute for Clinically Valuable Sciences, for those who don't know. It's essentially the health data warehouse in Ontario. There are no conflicts of interest to disclose, but I would like to acknowledge our funders for these projects, which is the Ontario Ministry of Health and Long-Term Care and CIHR. Of course, this work is not possible without the full team. So the team is led by Dr. Doug Manuel and also Peter Kenny-Petruccio. And we are supported by a number of analysts, research coordinators, research assistants, as well as a partial web development team. So today I will start by giving you a brief introduction to the current state of palliative and end-of-life care in Ontario, what we think the issues are with the current delivery models, and how we can actually use data to not only inform care planning, but potentially to improve palliative and end-of-life care in the community. And that's when the RESPECT algorithm comes in, and I will speak a little bit more about our mortality risk algorithm. And then I will move into sort of what we think this area of research is moving towards. So from health administrative data to what we call big data. And I think big data has been used in many different contexts, and sometimes it's a misnomer, because when you take the idea of big data to other sectors, they look at health data, they think, wow, a couple of million records is actually something that they collect every single second. So it's not big data, for example, to people in IT. But we're thinking, so I'll elaborate more on that, but we're basically thinking that that is the direction where health research is moving. So I'll sort of tie in our project with big data, the idea of big data, and then finally I'll end up with sort of a showcase of some of our other ongoing projects in the area of palliative end-of-life care using ICES data. So I think if you've actually heard Peter present some of this material here before, you'll know that a lot of people in Ontario who die do not receive palliative or end-of-life care in the last year of life. And that's unfortunate, because when we look at data, in the year prior to death, approximately only 52% actually receive any formal palliative or end-of-life care in this province. And 85% of them are receiving care in a hospital setting, and approximately 20% are receiving care in a home setting. And we know that there are certain differences based on what kind of health and comorbidities that you have. So for example, cancer patients are twice as likely to get palliative end-of-life care than non-cancer patients, and that's what we expect. We do have a very good cancer care infrastructure in Ontario, so that's not unexpected. But we also know that a lot of older adults are dying in the community with other chronic illnesses, and a lot of them are just frail in general. So they receive the level of support that a cancer patient may require in the last couple of weeks of life, but they're not receiving the same amount of care. So we think that the issue with delivery is essentially an overlap of several areas. First, in Ontario, we see that, as I mentioned, suboptimal, we call suboptimal execution. So we know that there is a need, but only half of the people in the province are actually receiving palliative end-of-life care. And part of that may be because we are actually not that great at making prognoses. So I think a lot of healthcare providers, especially with clinicians and palliative care physicians, they have more expertise and more exposure in this area. You know, they tend to make better judgment, but a lot of times what we see is it's actually case managers in the CCACs who are making judgment calls about who actually should get palliative and end-of-life care. And a lot of times they don't have all the information or the resources to help them to inform that decision. And what we see in the literature is that actually healthcare providers tend to overestimate the survival of their patients. And with increasing exposure or relationships, so the more and the better that the healthcare provider actually knows their patient, the more likely they're going to overestimate the survival. And I don't think that's surprising because when you have a relationship with your patient, I think you tend to be a little bit more optimistic. So this is evidence they found through focus groups with physicians and other healthcare providers. And we also think that there's suboptimal communication of risks. So sometimes there may be services available, and the healthcare providers actually know the prognosis of the patient, but they're not the best at communicating this to the patients and the family. And sometimes it's because the family and the patients prefer certain interventions, and they may not be ready for palliative end-of-life care. So we think it's an interaction of all these factors that makes it difficult sometimes and challenging to actually deliver good palliative end-of-life care in the community setting. So for example, one survey of elderly patients across hospitals in Canada found that only approximately 20% actually received a firm confirmation from their physician that they had limited time left to live. And other studies, as I mentioned, for example, as you see the scatter graph, scatter plot, you see that a lot of the predicted survival time periods are actually above the 45-degree angle, which tends to suggest the overestimation of survival compared to the actual observed survival of the patient. So, RESPCT, respect. This is a name that we it took a while to come up with, but we thought this is an acronym that not only represents what we think is the approach, the attitude that we should take to when talking about palliative end-of-life care, but it's also a great acronym for our risk prediction algorithm. So RESPECT stands for Risk Evaluation for Support, Predicting Elder Life in a Community Tool. So it is kind of a long name, but I think the acronym is great, and I think so far, when we pilot this and take the tool out in the community, a lot of people thought that this actually encapsulates the idea really well. So what is RESPECT? RESPECT is essentially an algorithm that we developed to address some of the not only policy but also methodological limitations that we've observed in the literature. So what we have seen with existing algorithm is that generally outcomes are presented as a probability. So for clinicians, for researchers, I think probabilities are intuitive. It's the number, it's the metric that we work with. But when you take this number to patients and family, sometimes it's difficult for them to interpret, well, what does it mean when I have a probability of 67% of death in the next 6 months? So how do you actually implement that in care planning? So basically, that's the first challenge that we had. And essentially, what RESPECT does is we predict survival time rather than probability. The second limitation that we've noticed with existing algorithm is that a lot of these algorithms predicts long-term outcomes, so 5 to 10 years. So your mortality in the next 5 years for a community dwelling population. And that's intuitive because generally when a person's in the community, their survival is longer than in other settings. So for example, compared to someone in a hospital or a nursing home. But we thought, well, there's a lot of people receiving or needing palliative end-of-life care in the community, but there isn't a good tool out there that captures this heterogeneous population and predicts survival in a shorter period of time, for example, 6 months or 12 months. And most of these applications are paper-based. So with paper-based application, it's great, you know, you can print it out, you can take it to the patient's home, but at the same time, it's not adaptive. So for example, with a frailty index, you have over 70 items, right? So you can imagine going through all 70 items, checking off all these conditions, may be time-consuming for someone of low risk. So with an electronic application, we can actually adapt the introduction of questions that further distinguish people with perhaps medium needs from high needs with additional questions if necessary. If a person has no physical limitations, no other major chronic conditions, then perhaps all you need is a couple questions to indicate that, oh, actually, they'll survive beyond the prognostication period. So Respect was built using home care data in Ontario. We took information from, nationally it's known as a healthcare reporting system, or the HCRS. That's data that's collected by CIHI. Provincially, the data is housed at ISIS, and it's basically information that's collected using the RIGHT-HC tool. So for those who are not familiar with a RIGHT-HC tool, it's essentially a health assessment tool that contains about 200 items measuring various aspects of your health, your function, your cognition, symptoms, and signs of rapid health decline, as well as some socio-demographic information. So the inclusion criteria for a study was anyone who has access, so who's eligible for OHIP, who has received at least one home care, episode of home care in Ontario, and has to have had one full RIGHT-HC assessment between our study period. And at the time of the assessment, because our interest was in older adults, at the time of the assessment, they had to be at least 50 years of age. And we took our sample, which was between 2007 and 2013, and we divided it into a development cohort and a validation cohort. So essentially, we developed our algorithm using a subset of the full sample and then validated those estimates on sort of another set of the sample. So our development cohort consists of just over 436,000 home care users over a 7-year period. And we validate that on the subset of over 121,000 home care users. And the thing that actually really impressed us when we pulled this data was there were only 4 home care users with missing data. So imagine out of 400,000 records, only 4 users have missing data. So it's actually quite impressive, the wealth of data that we have in Ontario and through this home care data set. A bit of sort of technical description. We use a Cox proportional hazards regression to estimate survival, and both at 6 months and 12 months. And the purpose is that we wanted to validate against other existing algorithms at 6 and 12 months. But essentially, we can predict survival from anywhere between a single month up to 12 months, up to 2 years, and to validate against any other existing algorithms out there. As I mentioned, our main outcome is a survival time, but we will also generate conditional probabilities so that we can compare against the performance of other algorithms. So this is hard to see, and I understand, but this is basically, the reason I pulled this is because it's a schematic of all the predictors are in Respect. So overall, we have over 37 predictors in the model, and some of those are interactive with each other. For example, certain health conditions with, for example, cancer with chemotherapy, COPD with oxygen therapy. So some of these variables are interactive, and most of these predictors are also interactive with time because there's an underlying time effect associated with some of them. So overall, there's 37 predictors, which is actually more than a lot of the existing algorithms. And that's the power that we get when we have over 400,000 home care users and 1.1 million actual records of health assessment. So rather than showing you the regression table, which I think is sometimes difficult to interpret and not easy to see, I'm here to just present, because I think the main metric is, can you actually predict the outcome in your sample, in your population? So this is a standard calibration plot. On the y-axis, we have the probability of death. On the x-axis, we have basically ventile, so 20 groups ranking of risk from the lowest risk group to the 20th, which is the highest risk group. So essentially, we took everyone with a predicted risk, ranked them, and divided it into 20 groups, and compare the performance. So the bars in blue are the predicted risks, and the bars in red are the observed risks. So the proportion of people in that subgroup who actually died within that 6-month period. So we see that generally Respect is well calibrated. We're slightly under predicting in the higher, some of the medium to high categories, and over-predicting in the highest category. And that's sort of what we've seen in the literature as well, that in the highest category, it's difficult to get a prediction, especially because certain predictors, for example, having symptoms of decline, such as vomiting, nausea, dehydration, significant weight loss in the past weeks, as long as you check off on these boxes, it tends to increase your risk. So it's difficult to get more accurate risks predictions in the higher categories, and that's what we're working on right now, refining the predictions for people in higher risk categories. We're also interested in comparing across other categories that are meaningful to not only clinicians, but also to policymakers. So we compare the performance of respect to the observed risk of death across 5-year age categories. And again, in the highest risk categories of those who are 95 plus, we're slightly off. But in most other categories, respect actually does fairly well in predicting your risk of death. And then also comparing across categories of instrumental activities of daily living, so IADLs. These include things like your ability to shop, to meal prep, to manage your own finances and medication. So actually respect performs fairly well across all these categories, as well as the activities of daily living. So of course, the ones in the highest category, again, we need to work on better estimates for people in the highest risk categories. But generally we see that in terms of calibration, the predicted risk matches up closely to your actual observed risk of death in 6 months. We're also interested in comparing against other existing tools. So some of you may be familiar with the CHESS scale. So essentially the CHESS scale is often used to measure health instability, including...
So in the spirit of what you asked earlier to be interrupted so that there could be some discussion.
Yes.
Do you have any statistics on the goodness, like how good the model is, like an R-square and a Akaike index?
Yeah, so our preliminary C-stat is around 0.76, so it's not terrific.
Yeah.
It is quite a bit higher than some of the other algorithms. Most of the algorithms are around 0.7 to 0.75, 76. So we're on the higher end of that range. But ideally, we would like to aim for like a 0.8 and above. Mm-hmm. So that's what we're working on right now to better calibrate the risk for people in the highest risk category.
Mm-hmm. And can you just describe the C statistics being sort of the concordance, right?
Yes, exactly.
For the group.
Right, so then you, essentially what you want to do is you match these pairs in your sample to see whether or not a predicted person that will die actually matches their outcome. Right, so we predict that you will die and that person will, and then you basically match these samples and to get a sense of how well overall you're matching, your prediction matches the reality. Yes. And the calibration is essentially, as I mentioned, the proportion. So looking at proportion who die within each of the categories and then comparing that proportion. So now coming back to CHESS, it's a measure of instability and it also actually does fairly well at predicting your 6-month risk of mortality. So we wanted to know whether having an algorithm with 37 predictors is actually better than what we see with the existing tool. So this graph shows a relative performance between CHESS and respect against the observed proportion. So on the y-axis, these are percent point difference from the observed value. So then if your observed value is, let's say, 30%, if you see a 1% increase, that means your predicted risk was 31%, so it's 1% higher than the predicted proportion. So what we see is that respect slightly over-predicts in some of the lower CHESS categories, but I mean, the difference is maybe 0.1% off. In the highest risk category, we actually see that CHESS over-predicts survival by 6%. Respect does a little bit better. We're only about 4% over the actual observed risk. But when you add CHESS with other variables, so the darker blue bars of CHESS plus assessment type, plus age and sex and other variables, we see that actually improves the performance of CHESS. So CHESS scale by itself actually over-predicts the probability of death for people in the highest category. So respect, what we learned from this is that perhaps we don't need 37 predictors in our model to improve the performance, but having these additional predictors actually helps you to discriminate, to tease out people who are in higher risk groups that other tools may not be able to capture just because they don't have as many variables. So chess is actually based on approximately 8 items in the RAI-HC instrument. And essentially, it's an additive process. So every time you check off you have one of these symptoms or health conditions, and your score increases by 1. And that increases your score on the chess scale. So we find that having additional predictors improves discrimination. But there's also underlying factors that are not captured by respect or chess, which is potentially some of the time variance for people in the highest risk groups. So what we imagine is that a lot of these people die very quickly after they enter a home care program, and we're not doing a very good job at capturing what happens in the first month, in the first 2 months. And essentially, that's what's affecting our overprediction of mortality. So I think here I will pause very briefly because I wanted to demonstrate, I know this is being recorded, so unfortunately those over the web won't be able to have the opportunity to play with the tool, but I brought an iPad with basically with the beta site of the Respect tool, so then you can pass it around and sort of play with the questionnaires and the visualization that we're pilot testing in our focus group. So as I mentioned, the tool was really designed for the patients. And first of all, we're interested in whether or not this is information that patients will want. If we're going to bridge this gap in terms of prognostication and communication, is this information that will be useful not only to clinicians, to policymakers, but also to the patients? And that's the Respect web platform. So a screenshot of the web platform is here. As you can see, all these demographic variables, and also with all our 35 other predictors, are set up in the form of a questionnaire. And they actually are introduced based on the responses that you provide. So if you indicate you're older, if you indicate you have certain health conditions, additional questions will roll out. So you can play with some of those functions in the app to see how the piping structure works. We're also testing with different ways of visualizing the results. So as I mentioned, I think probability may not be as intuitive to some people, especially to a lay audience. So we're playing with different ideas of presenting probabilities as a survival curve. And this is a case figure, so essentially, out of 100 people like you, how many have the same survival rates? And then also different ways of presenting chess and other scales. So essentially the width of these bars represent the proportion of the population. So you know actually where you fall in the population based on the estimated score on these scales. So in addition to survival time, we're trying to present additional information that will help to inform the decision. For example, chess scales, your ADL, your IADL, as well as other scales that we may have, we may be able to generate using ISIS data. So our community partner is in Windsor, Essex. Essentially, I don't know if everyone here is familiar with the Compassion Care Community Initiative. So essentially, they're building the infrastructure around mobilizing volunteers and friends and family and neighbors to actually get involved in supporting one another. So essentially, they're sending volunteers out to follow up with people in the community, especially elderly in the community, and trying to get a sense of what their healthcare needs are. And they've designed a personal health record system that's linked to the EMR, so that the patient could actually have access to not only their EMR information that the physician decides to share, but also any other tool that is implemented in the community. So we're actually implementing Respect into the PHR so that when the person completes the Respect questionnaire, they'll actually get their score in their PHR, and they're able to track their progress over time. So this is something we're working on currently. Yeah.
So the Respect was developed using RAI that was measured in home care, because that's really
exactly
where it's done. But the intent is to use it in the community, not necessarily in people who've received home care. And so do you expect it to have the same performance? Because it could be the subset of people who are in home care are different from the rest who are in the community.
So I think even though Respect is developed using home care data, we believe there are people who are out there who may need these services but don't actually access home care. Whether it's because there's no home care available in the area, or perhaps it's because they didn't know that these services exist. So the tool could still be applied on them, and they may be a lower risk. So if they're actually of lower risk, so basically based on their response to some of these items, if they have no ADL limitations, no IADL limitations, very few chronic conditions, and no major prior healthcare use, then we might send them to our Project Big Life life expectancy calculator, or our CBD port, or CBD calculator, and other calculators from Project Big Life. That gives them risks that are more interesting or more relevant to the general population than the home care population. But as soon as you indicate that you have certain physical limitations, you have some levels of cognitive impairment, and several chronic conditions, then I think the actual right instrument would be informative for your care planning.
Yeah, I guess I'm wondering whether it's worth validating its predictive value in that community, because the home care variable itself, the fact that you're in the home care, could have a huge influence.
It is biased, right, by your propensity to use home care, yes.
Yeah.
And I think that's important. We do have a lack of data for people who are healthy and don't access home care. I think that's generally what we see in health services research that's generated from health admin data. So actually one thing that I would touch on is that through this collaboration with Windsor-Essex, we're not only collecting information that they're interested in, we're able to collect information that we're interested in. Because once a person fills out the spec, we actually have a better idea of what the community population is like. And that's actually linked to other outcomes like quality of life that we don't actually capture in health admin data.
It'd be worth see if they'd be willing to give their OHIP number so that you can look at the outcome and see how predictive.
Exactly. So actually that's something we're hoping will be an extension of the respect work. So both in terms of application to get additional data, but also to form this network so that we have more information.
Yeah. Question from our online guest: has the respect tool been validated in community-based sample? If not, are there any plans to do so?
I think it's exactly the same question. So we have not. We are currently still in development, and that's our pilot testing.
Yeah.
We're still testing the feasibility and acceptability of the tool. Yes.
So this, I guess, this assessment would provide to funders and policymakers information related to the risk of dying. It is somewhat separate from the actual needs of the patient, and I'm wondering if there isn't a bit of risk here for patients receiving perhaps more care than they need because they have a higher risk of dying, and the people who are not particularly at high risk of dying but at high risk of need, and therefore costly to the system, are going to receive less care. And I think that may be particularly true in Eastern Ontario, where it's very hard to get home care services established in the first place. And so we have patients who may not appear on the radar for policymakers and funders.
Exactly, and I think essentially, I think what we hope the tool will do is that the person, if they have access to this, could say, well, I have the same needs as people who are receiving care. And perhaps this is something that we should introduce to the policymaker for them to assess the care needs in a specific area where there's an underutilization or under delivery of home care services. And at the same time, we're trying to supplement this with other metrics, right? So things that are not specific to the home care use, but also things like quality of life, their perception of unmet needs, and that's what we're hoping to collect with our collaboration with Windsor-Essex. So then we can actually have other metrics that will have a better indication of need that's outside of what we're using for the home care program. Yes.
I have a comment about compassionate communities.
Yes.
This is, your presentation is very timely. There's a group of us in Ottawa, volunteers, led by Jackie Holtzman, a former mayor, and Jim Nininger, former CEO of Conference Board, that are in the process of looking at launching a compassionate community in Ottawa,
Yes.
which is really a social movement to in fact engage all levels of society, schools, the workplace, and so on, and understanding and normalizing kind of end-of-life issues and so on. So I'm only putting that out because there may be another testing ground for you, or
Yes,
community to relate to here, which would have some practical implications. much.
So we partner with Deborah Sattler in the Windsor Essex community, and she has mentioned that
Has she
to us
mentioned that?
before, yes.
So this is specifically for end of life then, compassionate care
Compassionate
communities?
communities, as I said, it's really kind of it's a public health approach to looking at end-of-life care. And obviously it doesn't focus on the medical side of things, it focuses on the social environment and how do we have this discussion in school, how do we have this discussion in churches, in unions, in workplaces, and so on.
There's definitely an emphasis on frailty. The movement in Windsor Essex, they do also focus on the caregiver as well, not necessarily people at the end of life, but just in general, caregivers who may need support for caring for an older parent. So it is a huge range of patients.
So congratulations on a very good talk so far.
Thank you.
I want to go back to some of your assumptions though, if I may. You said that only 52% of people who die get palliative care. How do you know, like how do you measure that? And do you in fact mean only 52% get palliative care codes billed by a specialist in palliative care medicine?
Mm-hmm. So it is driven by the information we have in the Health Admin databases, so in a way that it's palliative care that is coded.
Okay. So I would respond to you by saying that that's a huge underestimate, right? That there's a lot of palliative care being provided by family doctors that you're not getting. So that when you begin your presentation by saying there's a problem here, and you're underestimating.
So actually, it's not limited to specialists. They also apply to family physicians who bill for palliative care. We do recognize that there are people who provide palliative care.
Because the reality is a family doctor in full-time practice may see may have hit 3 or so people a year in his or her practice that die. And they simply may not be bothered to look up the special codes that billing codes that they would otherwise use infrequently. And, instead of spending a minute and a half looking up the proper billing code, you just bill your normal way and get on with your life.
Mm-hmm.
So I think that's an issue.
Right. So that actually
the
percentage actually represents the proportion who receive care in the last 3 months of life as well. So we do also place that wider capture for any care in the last 3 months. And actually, a lot of people are not receiving any home care in the last 3 months.
It's a sort of a picky point I'm using.
Yes.
But the reason I'm stressing it is because it's your first assumption in your talk.
Yes. And
this is an important problem. Listen to what I have to say because, and then, as a person in the audience, I'm thinking, well, that figure may not be right. So I'm kind of giving it maybe a little more. It's a picky little point, but I'm emphasizing.
No, I think it's a great point because
it's so basic to your premise.
Yes. So I think that's the first study we did in this area, looking at formal use of palliative care codes. So I agree that a lot of palliative care is not coded in that way. Yeah. And even though they are delivered, they're not coded in that way. So that first paper looks at the actual formal use of palliative care using palliative care codes. But there are other projects that I will be presenting towards the end of the presentation where we looked at services in general in the last year of life. And we do notice that the SRC 95 codes for end-of-life care, all the palliative home visit, those are not all of the actual care that's delivered in the last months of life. And there are people who indicate that they provide palliative care, but use other codes that are not necessarily SRC 95 or any of the home visit codes for palliative care.
Can I just ask folks to self-identify, actually, because Amy probably doesn't know most of the people. So when you're done, your point, Bill, just let her know who you are. And
Bill,
well, I know Bill because that's good.
So now I want to stress again, you're doing a great job, and I'm going to confront what you're doing, but don't take it the wrong way.
No, I completely agree.
I'm trying to be helpful, but
yes.
I think that's what we're doing here is it's a kind of a friendly, safe place. So this is the spot to get hoped.
Yes, I actually welcome that question
So-
because it does leading to where we're moving with this
Well,
area of research.
I'm just getting warmed up.
Okay.
So the second question I
Okay,
have for you,
sure.
around your assumptions, okay, is that you are clearly assuming that palliative care is useful. Now, you may, and I have, believed that it is, okay? But there was, you know, the POEMS thing that we all get from the Canadian Medical Association? There's this service that pushes out, and it's almost every day, something comes to us, and somebody has found an article that they find provocative or interesting or something like that, and they send this out to every physician in Canada, I suppose. And within the last 2 months, one of them was claiming that palliative care doesn't make any difference. And I can't remember it very well, and I'm looking around for my physician colleagues to see if they saw it, but it was, I can't remember what the outcomes were, but I think they were looking at, percentage of people who died at home and all sorts of other, I'm sorry, I can't remember, but I would, it should be possible to go back and search that database, and Doug Manuel would have access to that. So, again, it's kind of it's an assumption, right?
Mm-hmm.
And most people in any audience will think, well, of course, palliative care is good. But in some respects, maybe there's a downside to it. And there's, you would find some sympathy in some audiences that the introduction of palliative care as a specialty is undermining certain other things that are happening in healthcare. Particularly, a family physician can now simply abandon this part of his or her practice because, I'll just refer you to a palliative care specialist. And they, for whatever reasons, can't exist in every community. And so there may be some downsides to this. And it's, I think, reasonable for you to be prepared in case somebody's thinking about that in an audience that you're presenting to. So, just make my last comment is, I'm very interested that you plan to make this available for patients. I think that's really interesting. I think it's probably going to be difficult for this to be taken up in a widespread fashion by family doctors because they only would be in a position to use it a few times a year. They might forget. But making it available to patients, I think, is really, really the part that I find most interesting. Now, of course, it's obvious how home care case managers would benefit from this, but I think it's really interesting to think about how patients might use it.
I think all of your questions are extremely interesting, and I think all of them are actually sort of basically foreshadowing what we're trying to do with this research. And part of that is testing this tool with patients to get a sense of whether or not this is something that they want. And a lot of it was actually driven by the Windsor-Essex community saying that they're working with community volunteers and people who live in the community caring for someone or receiving care from someone, and they don't have the information to advocate for themselves. And that's actually their initial ask, to have a tool that's easy for patients and family members to use, and that they can take to their care coordinators or physicians, and policymakers, and say that there is a need in the community that's not being met. So a lot of this is ongoing work, and we are evaluating whether or not this is something that patient would even want. So I know I am running out of time, so I'll take some more questions towards the end. I also want to show some of our ongoing project, which will, I think, answer some of Bill's questions, and the group might find interesting. So focus groups, Doug actually gave a talk on big data a while ago, so I think some of this might not be new material. But essentially, big data is characterized by volume, variety, and velocity. So is health admin data big data? To be honest, I think if you take the same amount of data to other sectors, the answer would be no. Because 6 billion people have cell phones around the world, and that's the information they're collecting every single second. On a regular basis, they're getting information from every single person's cell phone every single second. Whereas health data, we generally collect mostly, every minute, hourly, mostly daily, on a daily basis. So in terms of volume, velocity, and variety, we're not quite there yet. But as you can see, with a project like research, respect, we're essentially turning research into a tool that could be used in the community. And that might actually motivate people to start monitoring and collecting their own health data. And some of this data could potentially be linked back to health admin data, whether through collection through Windsor Essex, through Project Big Life, or any other forum. So moving really quickly through this, our work has been used. So essentially we developed documents that could be shared with other agencies who are interested in implementing their own risk prediction algorithm. One of those agencies include the Heart and Stroke Foundation. The other agency is the Windsor Essex Community Groups. As I mentioned, they're developing this PHR to collect information from patients not only on quality of life, but also other health characteristics. And essentially what Respect does is that we predict what level of need, what group they're in terms of level of need. And in this case, that's all you see on the questionnaire report. The report that comes from the questionnaire is that you're in a moderate needs group, high needs, very high needs, or low needs. So potentially, people may not be interested in actual probability or survival time. But this is one way we're partnering with people in the community to serve a gap in their current service delivery. Skip through. So Respect and Beyond, I think some of this information that I present so far is on very specific application of health administrative data. We're basically developing a tool that serves a very specific purpose, but as everyone here has probably recognized and have brought up, is that that's not all palliative and end-of-life care. And we need to actually have a better understanding of how palliative and end-of-life care is actually delivered. So basically following the expansion of the work that we've done over the past 2 years, we are really interested in looking at other delivery models, both that are physician-based as well as home care-based. So our objectives were to sort Ontarians into these different care packages. Are you receiving palliative care from a physician? If so, what kind of physician? Are you receiving palliative care in the home care setting? If so, what types of home care services are you receiving? And then describe these populations, both in terms of their utilization as well as costs. And then comparing them to other people who have similar characteristics but are not receiving the same level of care. So if you have people with same characteristics receiving different levels of care, what is the impact of that care on outcome? So this is the direction we're moving with our research, and all the work that I'm presenting now are preliminary. So initially, what we came up with, one of the residents we worked with came up with this way of dividing physician-based model into these different buckets, both in terms of whether or not the person's a palliative care specialist, which there are certain ISIS codes that we use to identify someone who's a specialist, whether or not they are the sole providers or whether they're in a consultative model where they're a family physician but who consult with a palliative care specialist for these specific patients. And what we see is that there are wide variations across the LHINs. So on the x-axis, we have the 14 LHINs. On the y-axis, we have the proportion of decedents who receive any sort of physician-driven palliative care in the community. In this case, we're looking at specifically home care or home visit by a palliative care specialist. And that's defined by individuals who have over 10% of their billing codes using one of the palliative care codes. And what we see is that Toronto Central has the highest, as approximately 17% of people who die in the Toronto Central LHIN have received a home visit from a palliative care specialist. The LHIN with the lowest proportion is the Northwest LHIN, so only 1% of people who die in the Northwest LHIN actually receive a home visit from a palliative care specialist. So these are definitions that we're trying to tease out to get better understanding of, and looking at variations across jurisdictions and across population, so we can have a better understanding of actually what is being delivered. one of the outcomes we'll be looking at is cost. So this graph basically just shows you the average cost on palliative and end-of-life care across the LHIN. So specifically, this is the average cost across the last 90 days of life. And these figures are more or less similar across the regions. And where we'll see greater differences is between people who receive home care and people who don't. So people who don't receive home care, we have seen in the past that they have higher hospitalization rates, so their costs are naturally higher. So the other aspect or the other sector that we're looking into is a home care delivery model. So then, as I mentioned before, we only looked at SRC 95 in our first paper because that was a clear indication that end-of-life care was being provided. But now we're expanding our scope to look at other SRCs that are delivered in the last year of life. And what we see is that a lot of people receive SRC 95, but there are also people receiving other forms of supportive services.
Sorry, SRC 95?
Oh, sorry, service recipient code. I'm skipping a couple steps. It's just the code that are given for end-of-life care. So it ranges from, it starts from 51 for example, end-of-life and long-term support. But then 93, 94 are your long-stay maintenance type of support. And 91, 92 are short-stay acute type of support. So people are receiving different types of home care packages in the months leading up to death. And it's not always just end-of-life care. But we do know that when you have an SRC 95, you have this end-of-life care code, the intensity of service actually increases dramatically. So there is an impact with being identified as having palliative and end-of-life care needs. But we haven't looked at the outcomes associated with other care packages, and that's what we're planning to do with our upcoming work.
We've got probably just 3 minutes.
Okay.
Including questions.
Okay, so final slide. This is just to show that over the past couple of years, we have seen an increase in the home care delivery in the last month of life. And looking at the breakdown by your last service use, we see that actually SRC 95, what we know as end-of-life care, that only explains half of the home care services that people are receiving. So there are a lot of people who are receiving other services prior to death that we don't have a very good understanding of exactly what services are entailed, the level of, and as well as intensity, and the outcomes associated with them. So that is the other presentation. Sorry, I had to go through
So 2 questions from our online guest. One is to add to Dr. Hog's question. It's a question about the use of the tool by patients themselves. So they're saying, if I understand correctly, you're piloting that in the Windsor community. Are you concerned about or planning to measure any harms associated with the patient potentially? Sorry, it's really quick here. Be told by a tool that they have 3 weeks to live versus a healthcare provider or case manager using it.
That's part of our pilot testing, what metric people are interested in and what they find potentially could be harmful or potentially could have a sort of a negative impression of the person's level of risk. So I think we're playing with ideas of, well, maybe not probability, maybe not just survival, but also having categories. So for example, in the Windsor Essex, rather than saying you have 3 weeks left to live, you just tell them you have very high needs, and you have the support that person with a terminal illness might need towards the end of life. So we're playing with some of these wording and trying to mitigate the harm and the risks associated with having this information available. And currently, it's not publicly accessible, and potentially, if the results of our focus group suggest that this is not information that the public is ready for, this is not information that patients want, then then we won't launch the tool. I think it's pretty much, there's a lot of work, but it's as simple as that. I think the goal is obviously to improve care, but at the same time, we don't want to introduce unnecessary harm.
And there was a second.
Yes, and there's a second question. Do you have any information on the number of palliative specialists working in each of the jurisdictions that you showed?
Yes.
One would think that that would influence numbers.
Yes, exactly. So we do, and we actually, Claire's in the room, so she's, like, the work that she's done has helped us to come up with some of these packages. We've worked with people, other researchers that have looked at different proportions of billing and how do you make that definition. So we're testing out different ways of defining to get the number of physicians who actually provide care in each region.
We can take only one more question. Barry, you have one?
Yeah, I just,
Barry Bruce, community physician, good
Right.
card,
so, we're,
and researcher.
I guess with the strain, the economic strains that family physicians have been placed under, we've been looking at more assiduous billing practices, and one of them has been to use the Homer score, which gives us a predictor for patients' likelihood of surviving a year, I think it is. And so the billing is such that you can bill every month. Once you've identified a patient who is going to die, and this was my original question, what is your definition of palliative care? Well, if we're going to define it by a Homer scale, then we'll be able to bill once a month. And so you may see this proportion of patients who are getting palliative care rise as a mere artifact of economic stress on family physicians. Just a comment.
And that's definitely true. I think our impression is that currently we don't have a comprehensive understanding of how billing codes are used and who's actually using the billing codes, and that's what we're hoping to provide some insight with this work that we're doing.
Thank you, Barry.